All right, good afternoon, everyone. We'll go ahead and get started. My name is Danae Aber. I'm the Executive Director of the Louisiana Rural Health Association. Thank you so much for joining us for this webinar entitled Getting Back to Normal, What to Expect After the Public Health Emergency Ends. LRHA is happy to host this webinar presented by Patty Harper with Inquisite Consulting. This webinar will provide information and operational guidance for rural healthcare providers, specifically rural health clinics and critical access hospitals, on how to transition out of the COVID-19 public health emergency. This webinar is being recorded and it will be available along with a copy of the slides on our webinar, on the webinar recordings page of our website. And I will drop a direct link to that relevant page in the chat here momentarily. Your line should have automatically been muted when you joined the session. Please remain on mute to prevent background noise. You may enter any questions that you have in the Q&A box and we'll be sure to answer as many as we can. After the webinar, a survey should automatically open in your internet browser. We do ask that you please complete that survey. It's very brief. It helps us to continue to improve our future events, and there's a spot there for you to request any additional future education topics, so we make sure that we're bringing you up-to-date information that's valuable to you. So with that, I would like to welcome Patty Harper. Patty is the principal of Inquisite Consulting. She has over 24 years of healthcare experience in the areas of healthcare finance and reimbursement, health information management, compliance, and practice management. She began her career as a hospital controller and reimbursement analyst. She holds a BS in health information administration from Louisiana Tech and holds multiple credentials through AHIMA. She successfully completed AHIMA's ICD-10 Academy and was previously recognized as an ICD-10 trainer. She's also certified in healthcare compliance through the Compliance Certification Board, and she's a frequent speaker and content contributor for national, state, and regional organizations on these and other rural health topics, and currently serves on the board of NARHC. So thank you so much, Patty, for being here, and I'm going to hand off to you.
Thank you. I think I need to share my screen again, correct? Okay. All right. Okay. Am I sharing okay now? There we go. Okay.
Perfect.
Okay, great. Sorry, guys. You think we've done this enough, we would have this down. So what we're going to talk about today, and we're going to have time for questions, is getting back to normal after the public health emergency ends. And we've kind of been talking about this because we haven't known how long the public health emergency was going to actually last. And I'm talking about the COVID-19 public health emergency. And so now we have a drop dead date of May the 11th. That's less than a month away. And I think most of us have been preparing for it, but we just wanted to cover a few things to make sure that that everybody's going to be know what getting back to normal is, right? We don't know what normal is. Many of our rural health clinics have been developed and certified during the public health emergency. Some of our hospitals have gone through major operational changes. So we're going to talk about what getting back to normal is going to look like for hospitals and also for rural health clinics, because we have less than a month, right? So what's that going to look like? So it's been more than 2 years that we have been in the COVID-19 public health emergency. And I don't know where you were when we first realized that we were in such a mess. We pivoted every day on trying to find out how to do things, how to take care of our patients, how to get the supplies we needed. So we weren't operating normally. We were operating just the best we could, right? And so as certified healthcare facilities, whether you're a hospital, a critical access hospital, a small rural hospital, or whether you're a rural health clinic or another type of certified facility type, we have set standards and guidance that we're supposed to go on. And during the public health emergency, we were given some leeway, some waivers not to do business as usual. And those waivers are going away. And so this first slide is part of a CMS page. I'll have the link for it on the second page here. So these are our resources. The red link at the bottom will be a live link when you get the presentation, when you get that handout, go with the red links. So we have a number of resources CMS has for us. And so one of the things we're going to do is recap some of the waivers that I think are going to most likely affect us, or ones that we need to be more keenly aware of them going away. So when we talk about the hospital side of things, a lot of our hospital waivers had to do with managing patient surge. So a lot of those waivers gave us the ability to use some of our distinct part unit beds as acute beds, and some of the rules for admitting those patients and taking care of those patients. We were given a lot of flexibility in that. So the red link at the bottom of this screen is also going to take you to the complete waiver document that you see just the header of it on this slide. We're going to talk about a few of those waivers. One thing that is going to affect all of our certified healthcare facilities, hospitals, clinics, and other facilities is that we were given the ability to provide care off of our main campus, or in temporary expansion sites. This was true for hospitals, it was true for rural health clinics, it was true for other types of facilities, because we were trying to separate sick patients from well patients. We were trying to be able to perform screenings and COVID lab tests, and yet still see our well patients, or our non-COVID acute patients, and take care of their conditions. And so when the public health emergency ends for hospitals, everything is going to have to be done again back within an outpatient department of the hospital, and not in a temporary expansion site. We had hospitals that rented out old auto like oil change auto parts stores, and that's where they held their drive-through testing. Many of people leased space in a different part of town so that they could see well patients in one part of town and see sick patients in another area. So that is going to all go away, not only for hospitals, but for all facilities. Our temporary expansion sites, we will not have the flexibility to operate in those sites anymore. Another big thing on the hospital side, and if you're a clinic person, just hang on, we're going to get to the rural health clinic part of this, but I didn't want to leave our hospital members out either. So another big change in the waivers, what will go away, but is the waivers created very fuzzy lines between acute patients, skilled patients, patients in other distinct part units. So where we took care of patients when we were trying to manage those transfers, manage those surges, those lines got really fuzzy, and we could put an acute patient in a SNF bed or another distinct part unit. And we also could waive the 3-day acute stay before that patient could be put into a skilled or a swing bed. So all of that is going to revert back to our pre-COVID PHE requirements. So we're going to have to use those beds for what they're licensed for what they're certified for. We're not going to be able to play musical chairs with our beds. Everything is going to have to go back to those services being provided in the areas for which they are licensed and certified for. Also, for our critical access hospitals, we had a waiver on our average length of stay. So critical access hospitals can have an annual length of stay of 96 hours. So we're going to go back to that standard again. That was waived because we were having to keep patients longer to take care of them, because we weren't able to transfer them, or because even another hospital transferred them to us. So again, where we provide services, whether it's in an expansion site or an off-campus site or in a distinct part unit, We're going back to the way that we were before COVID. Everybody has to be where they're supposed to be, and those services are having to be performed where they are supposed to be. I think everybody's aware of that, but what you may not be aware of is putting those processes back in place to for that case management, for that utilization review, to make sure that we're managing those patients and managing those lengths of stay and those different types of care the way that we were supposed to be doing it over 2 years ago. Any questions before we go into the rural health clinics part? Any questions about the hospital waivers? There were also waivers for everybody on documentation, information gathering. We were again trying to scramble and take care of patients where as fast as we could, wherever we could. Some of our quality initiatives, quality reporting may have been put on hold. So circling back around to all of these different revenue cycle functions and making sure that those processes are back in place is what I would recommend. Just like there were flexibilities for hospitals, there were flexibilities for rural health clinics. Again, waivers that allowed us to take care of patients and pivot in the way that we did that during the public health emergency. The red link on this slide, which will be in your handout, will take you to this full document. Again, we're just going to highlight some of the high points of the waivers. So rural health clinics, and some of these waivers we didn't fully appreciate in Louisiana because of our state licensure requirements. If you didn't know, our Louisiana state rural health clinic licensing requirements are more strict than the CMS certification requirements. So some of these waivers, although they were federally implemented, we didn't get to appreciate or fully use those in Louisiana because of our licensing regulations. But when the public health emergency is over, all of our staffing waivers are going away. We still must have a nurse practitioner or a physician assistant or a nurse midwife staffing our rural health clinic 50% of the patient care hours. And I don't think we got much of a waiver on that. I do know there were some individual incidences where clinics had staffing issues. Also, physician supervision of nurse practitioners in RHCs and FQHCs, that is a waiver that's going away. Again, we have stricter supervision requirements in Louisiana than in the rest of the country. So I don't know that we fully saw that waiver. And the same thing with temporary expansion sites. CMS allowed us to have temporary expansion locations. We know that there are no satellite RHCs. That's a federal requirement. Each location must be separately certified. In Louisiana, every rural health clinic must be separately licensed. And that licensure is a prerequisite before certification. But some people did start new clinics and did have temporary expansion locations. If you did, those clinics have to be up and standing on their own as RHCs when the public health emergency ends. So this is what CMS said about the staffing waivers. So we know that, I already said this, nurse practitioner and physician assistant must be staffed at least 50% of all patient care hours. Federally speaking, a rural health clinic has to have a medical director. I'm just going to take a moment to talk about this because there's a lot of confusion about this and we get a lot of questions about it. The medical director role in a rural health clinic is a different role than the role of the supervising physician or the collaborative physician. So in Louisiana, we must also have a physician who is responsible for direction of the clinic. But the federal requirements in 42 CFR 491(8), when they discuss the medical director, that's a slightly different role than just what the State Board of Nursing requires for a supervising or a collaborative. So if you've had changes in those roles during the COVID PHE, you might want to revisit 491.8, and you may want to revisit Louisiana Administrative Code Title 42, Chapter 75, which is the RHC licensing regulation, to make sure that those physicians that you've put in place in those roles are aware of what their duties are and what their responsibilities are. In Louisiana, in the licensing regulation, the physician must still physically visit the clinic once every 2 weeks to sufficiently supervise the clinic. That's in our state regulation. The federal regulation says that the medical director must be able to provide services in the clinic, but it does not quantify the amount of time that that physician has to be in the clinic. So just be aware that the medical director role, the supervising collaborative physician role are not exactly the same role. And if you've put new people in place during the public health emergency, you really want to make sure that everybody's doing what they're supposed to be, that the job descriptions, the contracts, the agreements all line up. On the federal side, we still have the ability for the RHC providers to be working from alternate locations. However, their ability to work from an alternate location does not, it doesn't, what's the word I'm looking for? It doesn't take away the requirement for there to be a provider in the clinic all of the patient care hours, and it doesn't take away from the requirement for there to be a primary care provider in the clinic. So I've said a little bit more than that slide did, but hopefully that was helpful. And again, we already talked about there are no satellite locations for a rural health clinic. You still will be able, from my understanding, to be able to have a tent or another structure outside of your clinic at the same physical address to do patient screening and testing. There's actually some federal money still available for some of that. So when we're talking about expansion sites, we are not necessarily talking about modifications you've made to your physical address, only that if you've changed an address. Okay, I think I'm good on that. I think we're good on that. You guys are a quiet bunch today. If you ask questions, we will answer them, okay? During the public health emergency, a lot of us had problems with plummeting volumes, so we did not meet our productivity standards. So on the Medicare side, our rates are calculated by the number of encounters we have. If we don't meet that productivity standard, then we have to use the number of encounters that we were expected to have had in that rate calculation. RHCs have always been able to get a waiver from the productivity standard, and that will still be the case moving forward. It's going to be super important for someone within your organization to be monitoring your cost and your encounters as you go through the year, especially now that we are all subject to upper payment limits. We want to make sure that we're monitoring the number of visits we have. We're going to talk about telehealth in a few slides, and we're going to talk about when we get there, we're going to talk about why we really want to try to get the patients back in the clinic if we can, because your telehealth visits are not included in your visits that go into your productivity standards. And so we really want to be in communication with your cost report preparer, want somebody modeling your cost and your visits as we move forward. So we're going to talk about telehealth because that's a big question. We get a lot of questions about telehealth. What's going to happen to Medicare medical telehealth after the public health emergency ends after May 11th, just a month away? So the good news is that on the Medicare side, we will be able to do telehealth as distant site providers through the end of 2024. And so we don't know exactly what it's going to look like. We hope by then we'll have permanent legislation that's going to allow us to count telehealth as an RHC encounter. But we do know that until 2024, we still will be able to provide distant site telehealth. If you're wondering what can you do that is on the approved telehealth list, what can be done, this is the link to go to the current updated. It was just updated in February. All of the CPT and HCPCS codes, which are approved by CMS for telemedicine. And so if you have a question about a service that you want to do, if it can be done by telehealth, this would be where you would go. For rural health clinics, this is a chart, and I actually got it from the National Association of Rural Health Clinics. Some of you may have been in on the recent PHE webinar that Sarah Holman did. This is a slide from that presentation. It's also available on the NARC website. It's a really good place to go when you're trying to figure out what type of service you're doing, how it's supposed to be billed, and what it will reimburse. So one thing with the end of the public health emergency, we did have an increased amount for virtual communication, and that's going to be adjusted. Chronic care management, and e-check-ins, and then on the fourth line down, the telehealth visits. So everything that is on the list that was on the previous slide is still going to be billed under G 2025. It is going to pay $98.27. So just be aware that although it's a great thing that we're doing telemedicine, that we're going to be able to do it through 2024, it pays less than most of your all-inclusive rates for Medicare. And it does not count as an encounter when you're reporting visits on your cost report. And the allowable costs have to be carved out of your cost report. So we really want to get patients back into the clinic if we can. We love the fact that we have the flexibility to continue telehealth, but we really want to try to let those patients know that our clinic is safe and that we would like to be seeing them face to face. Also, on the telehealth visits, all of the preventive services are included in the list of codes that can be billed under G 2025. But when we bill G 2025, neither the patient or that provider gets credit for that wellness visit or that qualified preventive services. And we're going to talk about a little bit more as we move forward, but mental health telehealth visits, those now are considered RHC encounters. We do get our all-inclusive rate for mental health telehealth. And we're going to look at that a little bit closer. And so this is on the Medicare side. This is traditional Medicare. So when we talk about Medicare, we're talking about red, white, and blue Medicare. How you're contracted with your Medicare Advantage plan, or what that Medicare Advantage plan's billing guidance is, may vary from what we're looking at right here. This is another chart that came from the National Association of Rural Health Clinics, and it is available on their website at the link that we have shown below. And it's just going to talk a little bit about, it's very easy for us to confuse originating site with distant site. So originating site is when you are hosting that patient in your clinic, but another provider somewhere else is actually the telemedicine provider. And it's that offsite telehealth provider who will be billing for that service. In that case, the rural health clinic only, and also critical access hospitals only receive an originating site fee, which is much less than the distant site reimbursement. So be careful when you're transitioning and you're getting into contracts with telemedicine vendors, that you understand the difference between originating site and distant site, and what those requirements are and what the difference in reimbursement are. Until the public health emergency, RHCs were not allowed to be distant site providers at all. We were statutorily prohibited from being distant site. Which meant we could only host the patient. Now our providers can be in the clinic, or they can be in their homes if they're precluded from coming into the clinics, and the patient is somewhere else. So distant site is the provider is in the clinic or in another approved location, but the patient is not in the clinic. Originating site is where we are hosting the patient, but the telehealth provider is a non-RHC provider outside of the clinic. And so we already looked at the G2025 policy for telehealth and looked at what that reimbursement is. Another very important thing about telehealth is, now that the public health emergency is over, we must have a HIPAA compliant method method or modality for telehealth. So we enforcement was waived on HIPAA approved or HIPAA compliant means of transmission during the public health emergency. So by now you should have an actual telehealth medicine module as part of your EHR, and that module should be compliant. So no longer will we be able to FaceTime our patients. We'll need a secure method of communication and transmission.
Hey, Patty, we have a question regarding originating site versus distant site.
Okay.
If you have one clinic where the patient is and another clinic in your network where the provider is, can the RHC not bill for both?
Okay. Are both clinics RHCs?
Yes.
That's a great question. Okay, the same RHC cannot bill originating and distant site.
I would think, Patty, I think in Louisiana, we can't have, they would have to be under two separate tax IDs just to exist, right? So they would bill separately anyway, right?
If they have common ownership, they're going to be under the same tax ID. If they have common ownership, they're going to have different NPI numbers. So that's a great question. So the originating, and I think Jeff is on this call if he wants to chime in, if he knows the answer to this. I haven't ever had that question exactly that same way before. It's possible that one site could be the originating site and the other one the distant site. That's a great question.
I would think, and we would need to verify, but I think if it's different tax IDs, you could. If it's the same tax ID, you couldn't. Right? Does that sound right?
Well, if it's the same ownership, they're going to be the same tax ID. They don't have different tax IDs to be if they're the same ownership. So if the same legal entity owns both rural health clinics, they would not have separate tax ID numbers.
Right. And I think if it's the same tax ID, I don't know that they could bill both.
Yeah, I see what, yeah, I see what you're saying. Can we get back with you on an answer? Because I'm like Danae, I want to make sure we give you the correct answer. And we have not gotten as much guidance from CMS as we really have needed on some of this. They have not been really clear with what's going into 2024, and they haven't really given us a lot of guidance on examples just like that. So please let us get back with you so that we would rather give you the correct answer than just tell you what we think it is. So and that's Tammy. So Tammy, we will get you a definitive answer on that. Thanks for asking the question. All right, I'm going to move on ahead. And so we're going to go from talking about Medicare medical telehealth to Medicare mental or behavioral health telehealth. So as of 2020, we can do mental health telehealth in a rural health clinic for traditional Medicare. It is considered an encounter. It goes on our cost report as an encounter. It pays our full all-inclusive rate. So this was a big win for us. And I'll talk about why it was a little bit disappointing in a minute, but this is great. So there are some conditions where the patient has to have been seen face-to-face before the telehealth visit before those visits begin, and then they must periodically be seen face-to-face with that patient unless there's a reason why that provider thinks that it's best for the patient not to have to come into the clinic. And so this link down here on the bottom of the page for mental health telehealth, it's special edition, MedLearn Matters Special Edition 22001. It goes into the qualifications and the requirements for the live visits. And so, but our problem that we're having with it is our mental health telehealth visits are reported under revenue code 900. So revenue code 900 is behavioral health. It is not the telemedicine rev code. The telemedicine rev code is 780. So these that go under behavioral health right now, there are only these 7 CPT codes that are currently matched to revenue code 900. So when we're reporting those mental health telehealth visits, we are limited to the number of CPT codes that are a correct match to revenue code 900. This is being worked on at the federal level by several different groups. So we would report revenue code 900 on our UB claim. We would report whichever appropriate CPT code is reflected for that service. We would have the CG modifier because it's paying the rate. Anytime we pay the rate, we use the CG modifier. The CG modifier basically says, pay me my rate. And then if it is a 2-way synchronous communication, audio visual, we will use modifier 95. If it's audio only, we will use modifier FQ. And you want your documentation to support why it was an audio only visit. So, so these visits are good to go. They're not affected by the end of the public health emergency. They pay our encounter rate and they count as visits that are reported on the cost report. None of the costs for these visits is carved out. So this is our big win for Medicare, and this will not change. Hopefully, as we move forward, our medical telehealth will be treated the same way. I wanted to talk a little bit about Louisiana Medicaid, and some of you may know more about this than I do, so you're welcome to chime in. We have been able to do distant site telehealth in Louisiana for Medicaid as an RHC encounter for several years before the public health emergency. And so there's no change in the way that we are allowed to do distant site telehealth for Medicaid. The place of service is O2 unless the patient is at home, which is a place of service 10. We use our T1015 code to say that we had an RHC visit. We report all other service lines with the appropriate codes. Every CPT code, the T1015 and everything else that we report, they all must have the 95 modifier appended to that line of the claim. And this will reimburse the RHC encounter rate for Medicaid. So nothing is changing with this. If you need more guidance on this, there is a LDH informational bulletin that discusses telehealth for rural health clinics. And it is still a current bulletin. It was revised in 2022 during COVID. It's still a current bulletin. It has not been retired or updated since this date. And so there is the link where you'll go to that bulletin. For Louisiana Medicaid, RHC behavioral health, and I'm not talking exclusively telemedicine here, we also have another LDH bulletin that came out in last January. It's a pretty complicated bulletin. I don't know if you've looked at it. It discusses which provider types in which settings can bill which behavioral health services. I apologize, I did not put the link to this bulletin up. What I did want to let you know is I have made notes on this bulletin to kind of translate the provider types and the locations. And so if you will email me, I will send you the copy of this bulletin that I have that's kind of a cheat sheet to which behavioral health providers. And Danae and I were talking before the call started. If you've had any trouble getting behavioral health providers added with the MCOs for your rural health clinic, if you could let one of us know, we're kind of trying to track what kind of problems clinics may be having with adding behavioral health providers to their clinics. Okay, so this is the one thing, changing gears here. This is the one thing that does not change when the public health emergency goes away. The COVID vaccine mandate for all certified Medicare facility types does not end with the public health emergency. And so for all certified CMS facilities, hospitals, ambulatory surgery centers, nursing homes, any type of a facility that is certified by CMS, Congress went in and changed the conditions of certification to include the COVID vaccine mandate. So this was not a waiver. This was not something that just was implemented during the public health emergency. Until Congress takes this out of the conditions for certification, everybody still must go by these requirements. And those requirements, I've just kind of bulleted them here for you, is all employees and staff, contracted workers, W-2 workers, students, those contract phlebotomists that are in your facility all the time, those drug reps that come in every single week, anybody that is in your clinic regularly must now be fully vaccinated 10 days before they begin work, or they must have a properly executed and approved exemption. So that can be a medical exemption or a religious exemption. And if if your facility has accepted exemptions, then those employees must be accommodated. So you have to show how you're keeping that employee and your patients safe from the fact that you have somebody that is not vaccinated in your facility. That may mean changing where they work or when they work. It may still require them to be masked. We get this question all the time: is the masking still required? It's not necessarily required, but it may be what you need to do to accommodate that individual with an exemption. That exemption that's been granted to that employee is just like an ADA accommodation. We have to accommodate to make sure that that employee is safe and that they are protected from their non-vaccinated status. We must have full record keeping of vaccines, immunization records for not only the initial doses, but any boosters. And we're supposed to have proved that we have educated our employees on COVID-19 and the benefits of immunization. And the last thing that's required is a contingency plan for your facility if infection rates surge in your community, or if your workforce is negatively impacted by employee absences or community surge. So the COVID vaccine mandate requirement is not going away. until it is removed from the conditions of certification for not only rural health clinics, but hospitals and all other certified facility types. So, so I know that's probably not what some of you wanted to hear, but I just don't want you to be caught off guard. We have got a few more minutes, and I'm going to end with going over both common RHC survey deficiencies and common hospital deficiencies. Now that the public health emergency is ending, our infection rates are down. Surveyors are back out in the field, and we are seeing surveys almost weekly. We are writing plans of correction almost weekly. So I want you to be prepared for what surveyors may be looking for by telling you what the most common deficiencies are. We're going to start with the RHC ones. This actually came from QCOR. You may not know it, but there is a database where we can go, you can go. It's a public access database, and you can see what the deficiencies are in your state or in your region for your type of facility. So these are the rural health clinic ones. The left column are the survey tags. So the J tags are actually RHC survey tags. The E tags, the tags that start with E, are emergency preparedness. So you can see how many of the deficiencies, and this is for the whole Dallas CMS region, how many of those deficiencies have to do with emergency preparedness. And then a lot that have to do with physical plant and environment, and some that have to do with clinics that moved during the public health emergency and didn't notify CMS. So if we move, we must notify them. So I just have bulleted and kind of taken the survey tags and translated them into main categories for you. We are seeing clinics every week be cited for not having their program evaluation. So the Louisiana requirement is still for an annual program evaluation with our Louisiana Advisory Board meeting. The Louisiana requirements are different than the federal requirements on this point, so I don't want you to be caught off guard on that. So if you have not done your program evaluation and you have not had your advisory board meeting, you need to get that information together and hold that meeting as quickly as you can. Most of us have our emergency preparedness testing done because we've been able to count COVID and our different weather emergencies as activations of our emergency preparedness plan, but we haven't written our after action reports. And so it's not enough that we documented that we had a flood. You may have some more severe weather coming to South Louisiana today and over the weekend. It's not enough that we've documented that tornado or documented that flood or documented that tropical storm or hurricane. We have to do our after action analysis, and we have to prove that we educated our staff. Also, if you participated in an online emergency preparedness activity, maybe just the clinic manager was in on that, that information has to be disseminated to the entire clinic, and education has to be documented for that. So just, it's not that we haven't done these things, we probably have done them, we haven't documented as thoroughly as we need to. Another common deficiency we're finding is we fell behind on our physician chart reviews during COVID. We were doing our very best to take care of patients, right? We were having gaps in providers. We lost providers. We had new hires. We had new medical directors, new supervising physicians. So maybe we fell behind on the physician chart reviews. Louisiana licensing law says that 10% of our NP charts have to be reviewed by a physician at least quarterly. So it's really easy to fall behind on those. So you'll want to review those processes, make sure that you have that in place and catch those up, or show that you are, getting back on track on that process. Part of the program evaluation and the advisory board meeting also includes that the medical director, the outside reviewer, that the providers, everybody that's supposed to review the policies and procedures annually, attest to that. So you'll want some kind of attestation form. Another survey deficient we're seeing is, again, during COVID, our biomedical equipment companies, our bioequipment department at the hospital wasn't keeping up with inspecting and tagging essential patient equipment. So that is something we're seeing now. Same thing, we had some flexibilities on intake paperwork on the hospital and the clinic side. So we're seeing a lot of incomplete patient records with missing consents for treatment. And so you'll want to, again, go over that process with your front desk, whoever's scanning those in. If you don't have an electronic signature pad, what's the process of getting those forms into the records? Maybe we have a backlog of scanning we want to take care of. Drug and supply expiration dates are still the #1 survey deficiency nationwide. And so if you've had changes in staff, changes in how you get your supplies, you'll want to make sure that you have a process in place for that. 50% nurse practitioner PA staffing, that's 50% of patient care hours. In Louisiana, remember, our licensure law requires our clinic to be open 36 hours a week for patient care. This is not a federal requirement, it is a Louisiana requirement. So those are the common survey deficiencies we're seeing. I want to really quickly go over some of the hospital deficiencies. Guys, I just have a problem with my screen sharing, I think. Can everybody see?
We see the common hospital survey deficiency slide.
Okay, you see them and I don't. Okay. All right, I am not sure what's going on here. Let me get okay, now I can see them again. How about that? Now everybody can see them. Okay. So on the hospital side, they're the same types of deficiencies that you would expect that we see in the clinic, because we were just shuffling around taking care of patients. So we maybe weren't getting all the paperwork that we needed. We were having turnover in staff. And so these are a little bit different than the clinic. A lot more around patient care, of course, and more around patient rights. But I just want you to be prepared about what some of the hospital deficiencies are. And again, equipment, supplies, records, patient grievances, which is on the hospital one, is actually starting to show up on the clinic side too, as far as having a process in place for taking patient complaints and settling grievances. So you may want to look at that. So of course, the hospital ones have a lot more to do with things that would revolve around inpatient care. But surveyors are back out everywhere. We've got time for some more questions. I always let you have both my email and my cell phone number. I will answer any questions as a follow-up to this to make sure that I've been clear. Again, if you want that behavioral health bulletin from LDH, the one that I've kind of made into a cheat sheet, I'll be glad to send that to you. And other than that, we can just take questions. I'm going to stop sharing now, and then we can just take questions, Danae, or if there's something else that you need to let the members know about.
No, we'll go ahead and we'll wait a couple minutes in case anyone's typing questions. Let's see. We do have a question for Medicaid reimbursement. Did I hear that you could still have providers work telemedicine from home and be reimbursed for the distance site?
For Medicare, that is on Medicare, on the Medicare side. I don't know about the Medicaid side. I haven't seen any guidance on that. There's a bulletin that they've been updating the whole time we've been in the public health emergency. And honestly, I did not check it. Perhaps I need to check that, and then we need to send out any additional information.
Yeah, and I will add, we are working on our end to look through all of the state specific stuff that was changed or waivers that were added, informational bulletins, things like that at the state level. And what things are going to remain in place and what things are going to sunset or be added or whatever. So we're working on putting together kind of an FAQ document to get that out relatively soon, as soon as we can. So we'll be looking at that bulletin. That's one, but Medicaid put out a lot of bulletins throughout the public health emergency. So it's taken us a little while to kind of comb through them, but we're working on getting you guys some information.
That'll be
get a printout of the webinar. So we are, we will send out you'll get an automatic email thanking you for attending the webinar, that sort of thing. And then the link is in the chat, and it should also be in that follow-up email to our website where the recording will be and the slides will be. I see Jeff has his hand up, so let me see if I can allow Jeff to talk.
You sure you want to do that tonight?
I can cut him off if I need to.
Can you hear me?
Yes, we can.
Okay. Well, the only reason why I raised my hand is because I have had 2 comments this morning from other people. President Biden signed into law the cancellation of the national COVID-19 national emergency. And many of our clients are asking, well, does that mean that the PHE is over prematurely than May 11th? And I just wanted to communicate the national emergency, the COVID-19 national emergency that was signed off on by both House, Senate, and the president does not affect the PHE. The PHE stays in effect until May 11th.
Thank you for that clarification.
And on the thing that Tammy was talking about, as far as I don't believe that there is any issue with 2 CCN numbers, because they're both separate. That one could be origination and one could be distant site, even though they're by the same owners, because every telemedicine is going to have origination and a distant site on every one, and they're not double dipping in any way, form or fashion. And so unless that there is some other requirement that Stark or some other place would have, as far as how the clinics work with telemedicine, it would be okay to have the same ownership, but with 2 separate CCN numbers, one with origination and one with a distance.
Okay, so as long as it's 2 different CCNs.
Right.
Okay.
And it would have to be, in the way this works is we can't have satellite locations, so they would be separate independent clinics, even though they have common ownership.
Gotcha. Okay. Tammy has another question. Does the patient have to be back in the brick and mortar clinic to do telemedicine before they could be on their phone and FaceTiming?
For mental health, there's the requirement to have an in-person visit before the telehealth starts for the mental health, for behavioral health. Am I right on that, Jeff?
Yes, but I'm not sure that's fully the question. Danae, say that again.
So the question is, I'll rephrase it a little bit. The question is, can the patient be at home during a telemedicine visit, or do they have to be at a designated originating site?
Oh, so the originating site is where the patient is in the clinic being hosted to be seen by an outside provider. But a distant site visit would be the RHC provider could provide a distant site service to that patient in their home. And I don't believe there's a requirement that patient have already established service with that provider.
Yeah, I think the question is basically, can the patient be at home?
Yes, the patient can be at home for Medicare and Medicaid.
I see Randy has his hand. I'm going to allow Randy to talk and
Oh, I always love Randy to talk.
retain my right to shut him down if I need to.
Can y'all hear me okay?
Yes,
we can.
sir.
Hey, y'all, I have become aware of a slippery slope regarding prescribing controlled substances. And Patty, I will send you all the information that I have developed on it and found out. But based on my understanding, for any telehealth visit beginning on May 12th, which is when the PHE after the PHE ends on the 11th, if there has been no established telehealth relationship with the patient during the public health emergency, there must be an in-person evaluation of the patient before a Schedule 2 through 5 controlled substance can be prescribed. The DEA has some proposed rules out there that could change that, but we don't know what has happened, what is going to happen with those rules yet. So what they're suggesting that providers do is go ahead now and be proactive and start attempting to initiate in-person visits. And with new patients, especially any new patient after the public health emergency, there must be a visit first unless the rules change. So I think everybody needs to know that. You could be doing one thing on the 11th and something else on the 12th and be violating a standard.
Okay. That's great information, Randy. That's really good. And it makes sense, doesn't it?
Absolutely, it does.
All right, we have just 2 minutes left, so if there's any one last question we can take. We probably have time for just one more question.
And I'm having battery issues here for some reason, so I hope I last the last minute. Thank you, everybody. If you have a question that pops up or you're sharing this information with somebody in your facility and they have a question, reach out to us and we'll all do our best to get you the correct information.
Yeah, seeing no additional questions, we'll go ahead and we'll close out. So thanks so much, Patty. Thanks to everyone for joining us. Just a quick reminder to please complete the very brief survey when you close out. As I mentioned, the recording and the slides will be on our website within the next couple of days. That link is in the chat. And as always, please feel free to reach out to us. Patty's email you'll also have if we can be of any assistance at any time. So thanks so much, everyone, and have a wonderful afternoon.
Thank you, Danae.